What's up, future respiratory therapists? In this video, we're talking all about intubation. This is actually part one of a two-part series focused on the intubation process. Let's dive in. All right, so as I stated, today's video is all about the intubation process. And today, we're just gonna focus on one of the key tools used during the intubation process, that being the laryngoscope. Now, you can see here in this image, this individual is utilizing a tool here to help them visualize the glottic opening so that they can put an endotracheal tube into the patient's airway and facilitate mechanical ventilation. Now, when we talk about the laryngoscope, this is the handle. It looks just like this. Now, we're going to talk about blades specifically here in a second. But before we talk about the blades, let's just talk about what makes up this laryngoscope. First of all, there's obviously a handle, and it's usually kind of I don't know what I'm trying to say here, a manufactured metal. It's not smooth so that you can grip it, because when we're utilizing this device, we need to be able to have a good grip on it. And so it's very, very textured is the word I'm looking for. Now, again, we're going to talk specifically about blades in a second. But here is one example of a laryngoscope blade. You may notice that since I have picked up the handle, it has only been in my left hand. And if you are practicing and you are preparing for maybe a lab competency, or you are practicing this in your lab, that's a key element to understand, is that the laryngoscope should always be, specifically the handle should always be in your left hand, because that's the only hand you will utilize to facilitate intubation when using a laryngoscope. Now, so that's point number one. Point number two is how do you connect the blade to the handle? And it's very simple. You take the handle in your left hand, and you'll notice there's a bar right here. That bar is very, very significant, because that bar is going to go into this little divot into the blade. This is where the two connect. So you take your blade in your right hand with the divot facing inwards. You take the blade with the bar facing inwards, and you're going to keep both of them facing down and just click on like that. And right now, we are ready to go. Now, when I open it, now you see this, now this moves, right? Now, when I raise this up, you will notice a light comes on. That light is the result of this piece of the blade meeting that activator within the handle. And that's what makes the light come on. Obviously, the light is on the blade portion. The power is within the handle. So let me show you what I'm talking about. If I unscrew the bottom here, you will see where there are batteries located inside of this handle. And so these batteries are what provide the power for the light source. The blade itself is located, not the blade itself. The light itself is located on the blade. You can see the light right there. So when you connect these two and open it, there's that light I was talking about. That light is very, very important. If you ever connect them, and this is something you should check to make sure that you have a good connection. If you ever connect these two and the light doesn't come on, then check that you have a good connection at your light bulb. Maybe your light bulb is burned out and you need a new bulb. If it's not, this is not the easiest thing to do while trying to film a video, by the way. But if you have a good bulb and you change the bulb out and it still doesn't work, then consider changing your battery. So you just have to know how to troubleshoot that. When you connect the two, you should have a light. And this goes for every single blade that you can find. You want to use this blade, there should be a light. You want to use this blade, when I click it, there should be a light. I'm always going to double check that before I begin the intubation process, okay? So that's kind of how you put the blade onto the laryngoscope itself. It will hinge when it's in the appropriate manner. I see students try to do this backwards all the time. They try to go like this, and that doesn't work. It looks like it would, but you're not going to get a light because it's not set up correctly. So remember, bar facing inside, divot facing inside, on, up, and you should get a light. That's how you connect them. Now, to disconnect them, you break back down and raise up. That's how you break it back down, because these pieces need to be clean. They're going to be cleaned separately. They're not going to stay, it's not going to stay like this and go back to somewhere. You're going to separate them, and then the processing for the cleaning process begins separately. Now, I know I told you we were going to talk about blades here, and I want to show you the difference between these two blades. First of all, you have what we call a Miller, and you also have what we call a Macintosh. These are the two very distinct blades that can be used during the intubation process when you are utilizing a laryngoscope. Now, the Miller is a straight blade. This is why I have the L highlighted here, because it's straight like the letter L. The Macintosh is a curved blade like the letter C. So you can easily remember if somebody says, "Can you get me a Miller blade?" Then you know I'm looking for the straight one. If somebody says, "Can you get me a Macintosh?" Or they'll probably just say, "Can you get me a Mac?" Then they're talking about this blade, curved versus straight. Okay, so you need to remember that as well. Now, these come in various different shapes and sizes. So this is a Miller 3. This is a Miller 2. You can see that somebody with a larger anatomy might require a larger blade. Somebody with a smaller anatomy, maybe a smaller blade. Somebody in the pediatric world would actually even require a smaller Miller blade. And so we can see that you want to judge the appropriate size based off of your patient size, so you know which one to use. Now, the same is true for the Macintosh. This is a very large Macintosh. This is the number 4. We can go down to the number 3. You can see that it is smaller in size when we hold them up side by side here. We do it like this. You can see that this one is clearly smaller than the 4. This is a 3. And then we also have a 2 Macintosh that is smaller than both the 3 and the 4. And so, again, which one would you use? Well, it would vary based off of the anatomy and the size of the patient that you were trying to intubate. Now, this is the most important part of this video. Why is it important to know the difference between a Miller blade and a Macintosh? Super important, because while they achieve the same purpose of aiding the insertion of an endotracheal tube into your patient to facilitate mechanical ventilation, they are not designed to be used in the same fashion. So let's talk about that for just a second. We're going to start with the Miller. So when we talk about the actual procedure, which I'm going to demonstrate for you in the next portion of this series, the Miller is designed to be placed directly onto the epiglottis and then raise it or displace it directly. So it directly displaces the epiglottis. You can see here I have an image of an airway. This is the tongue. As you were to move in with your laryngoscope, you would see the base of the tongue. You would see the vocal folds, and then, or the vocal cords, and then you would see the epiglottis. Now, this blade would be placed right onto the epiglottis and then move it up so that you can see that glottic opening so that you can insert an endotracheal tube. That's very different than what you're going to do with the Macintosh blade. The Macintosh blade is going to go into the oral cavity. You're going to move down the base of the tongue. But you see this space right here? This space this space right here between the base of the tongue and above the epiglottis, that is called the velecula. You want to remember that, the velecula. Now, the velecula is the space where you're going to put the Macintosh blade, not onto the epiglottis, but just above the epiglottis into the velecula, And then you're going to raise, and that is going to indirectly displace the epiglottis so that you can see the glottic opening and insert your endotracheal tube. So the key words there, if you're a respiratory therapy student today and you're learning about this, I promise you there will be a question on your exam. Which blade directly displaces the epiglottis during the intubation process? And the answer to that is the Miller. The other question you might get, or maybe both of them on the same exam, is which blade is inserted into the velecula and indirectly displaces the epiglottis to aid insertion of an endotracheal tube during the intubation process? And the answer to that question is the Macintosh blade. And that's the basics you need to know when it comes down to the equipment you will be using for this lab and for this procedure in a hospital setting is how to hold the laryngoscope in your hand the appropriate way, which I'll demonstrate again in the next video, and which blade you're going to use and in which way you're going to utilize that blade. Very, very important stuff right there. So thanks for tuning in here. Do me a favor, if you will, hit the subscribe, the like, leave me a comment. Is this on par with what you're learning in your program? Is this what you're seeing out at the bedside? I want to hear from you. Also, if you will, check the video description below. I have the Respiratory Coach Academy, where I offer the TMC bootcamp to help you pass that exam, the CSE bootcamp to prepare you for the clinical simulation exam. Also have a formulas course, an ABG course, and a pharmacology. These are all mini courses to help supplement your educational journey. But the one I really want you to take note of is this one right here. This is the free cheat sheets. This is basically Respiratory Coach resources that I give you for free. There's waveform analysis. There are all types of resources within that course right there. There's a free ICU checklist so that the first day you set foot in there, you feel comfortable on what you should be looking at. We all want to run to the vent, but that's usually where we make our first mistake. Remember, patient first. Learn your patient first, then go to the ventilator and see what the ventilator is telling you about that patient. Very, very important. All righty. Well, that's the laryngoscope. I'm Respiratory Coach. Stay here on YouTube. Come follow me on Instagram at Respiratory Coach, TikTok at Respiratory Coach, LinkedIn at Joe Lewis. A lot of good professional networking happening over on LinkedIn. And if you have any questions, send me an email, respiratorycoach@gmail.com. I'd love to get your email, converse with you, and see what questions and what clarification I can bring to you. Remember, at the end of the day, average is easy. Don't be it.